Uh, he is our alumni from the BPT batch of 2000, and he's presently working in Highland Hospice in Scotland. And this year for the alumni meet, Giridhar was there. So when we showed our interest that we want, we were very excited to know that Giridhar is in the palliative, and which is something which we are not very familiar here in India. So when we expressed our interest from our side, Giridhar was overwhelmed to share his rich experience, what he is doing in the palliative care. So palliative care, end of life care. We have all seen in the books, but we in the real life, we have not practiced it as such. I believe Giridhar has learned it through his experience. He started working in this unit from 2008, and
Yes, yes,
then
ma'am.
yes, and then you have qualified in 2015, isn't it? For the same, for the
Yeah.
Highland Hospice, yes. 2015, you had a degree.
2012, I had my master's degree.
Yes, yes, 2012, and
2015, yeah,
yes.
2015, I've got my permanent residency and the citizenship.
Oh, great, in UK.
Yeah, yeah,
Oh,
yes, ma'am.
great. Yes, congratulations.
Thank you.
Um, I request all our Selvam, is it there are only 13 I can see as of
No,
now?
ma'am. There are 26 participants in total.
Okay, great. So I welcome you, Giridhar, and you give your rich experience to our students so that they take forward, they decide whether they are really interested to see in this field also is a very new concept to us when from here. So thank you for accepting, and thanks once again for delivering your experience to our students.
Thank you, ma'am. Thank you for inviting me to join in, because when I started doing this job, it was a huge challenge. I mean, some of you might have listened speaking to me when I was there in Manipal in January, but before that, I will start briefly about where it all started, and then see if I can share the. Can I share the presentation now, sir?
Just a
Selvam?
moment. Yes, yes, yes.
Okay, sir. So. Can everybody see the presentation?
Just a minute. It is not showing up.
Okay.
No, Selvam, it's not showing.
Yes, yes. We have tested already. Yes. Yes.
Can you see? Can you see the presentation now, sir?
Yes. Perfect.
Okay. Yeah. So my name is Giridhar Ravi. I kind of passed out in 2005. I started in 2000. I come from a small town called Ongole, which is in Andhra Pradesh, where I always wanted to become a doctor, obviously, but I could not have the enough credentials to become a doctor, pass the exam. So next best thing was to do something in the medical field that would enable me to stay close to the medical field. And I was an avid cricket fan, so that was an interest where I thought, if I can't become a professional cricketer, the next thing that can bring close to me was to be a sports physio so that I can be with the cricketers. That is my interest into physio. And coming to Manipal, where it kind of explored and opened up huge opportunity for me to learn not only about physio, but also about life in terms of the culture, in terms of the disparity in the knowledge base, and then also economical differences as well between each students as well. I wasn't a brilliant student kind of academically, but what I've learned being in Manipal was the peer support and also how to survive in any challenging circumstances. Somehow I managed to pass the course, which was really challenging. I don't know, sometimes I still wonder how I managed to skate through, given how challenging it was for me. And in 2006, initially, I've done my postgraduate diploma and started looking for jobs. And this job came up as a palliative care physio in hospice as a 3-month contract, temporary contract. But at that time, as some of you might be aware as well, I've only heard the term hospice, not knowing what to do. So that's when the peer support of all the seniors, so they were already in the UK, and other folks who are already come abroad. I was constantly on the phone with them, wanting to know more about palliative care. What should I do? So because this is being my first job, not working for any other discipline or any other service in the UK, that was a huge challenge for me to take up a job as a specialist palliative care physio in a hospice. But I somehow taken that leap of faith, not knowing what can I do, not knowing what can I offer. But within the 3 months, within the 3 months, for the first 6 weeks, I just put my heart and soul into it in terms of my enthusiasm and my keenness to help. And that was recognized by the organization Highland Hospice. And I was offered to apply for a full-time placement, even though they acknowledged that I didn't have enough experience of working in this field. I was offered the job, and then I've applied for it. And then again, strangely, I got the job, being as a full-time permanent physio working as specialist palliative care physio in the hospice. The hospice, Highland Hospice, is a charitable organization which is partly funded by the National Health Service, and the rest of the money comes from donations from fundraising. As well, we do have a core team of doctors, palliative care consultants, specialist doctors, senior palliative care staff nurses, healthcare assistants, social worker, bereavement counselors, day therapy, where patients come in just for one day, and also other huge volunteers as well that support the organization as well. So that's kind of basic background of how it's all started from Inverness to Manipal, from Manipal to Inverness, where started off of a small town boy coming from a small city and not knowing what he wants to become, with just a keenness and interest in cricket that made me to take the degree. And then again, the same interest brought me into palliative care. I mean, if you see a spectrum of physios from sports physio to palliative care, they are kind of extreme north and south pole, where you in sports physio, you treat people in a different way, you treat your players different way. And palliative care is entirely different as well, and with a different mindset, which I'll talk about in the presentation as well. So before I do that, I just want to kind of start off the main objectives from this session. I am not, as I said, I'm not great academically as well, so the presentation might not reflect on what I speak sometimes in some ways. I'll try to make that connection between the presentation and what I speak as well. But if you have any specific questions, please do ask me. Because I mean, my way of learning is always been verbal and then always been more interactive. And that's how I picked it up as well. And which hopefully some people would understand. But if the presentation doesn't make it clear, please do ask me what it means. I'll try to explain to the best of my abilities. So the main objectives, as you already saw in the poster, is to understand the role of physiotherapists in palliative care or end-of-life care, And it's my perspective. I mean, there's a huge literature that is there for anybody who's interested as well. But I'll try to simplify that as much as I can do based on my experience of working in here for the past 11 years, just over 11 years. And also the other objective would be is how to apply active listening skills as a part of your effective communication with the patients. And if anybody is interested in pursuing or wanting a career in palliative care, hopefully at the end of the conversation or at the end of this session, you'll be more confident in approaching and treating somebody with palliative care needs or end of life care needs. I'll touch on very briefly about what palliative care is. I mean, some of you might be aware. It's just so that we can start the topic, being it as physiotherapy and palliative care. The World Health Organization definition of palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and the relief by means of early identification and impeccable assessment and treatment of pain and other symptoms that could be physical, psychological, and spiritual. Palliative care was primarily seen as a terminal care, but its range and its scope is lately been extended to the concept of rehabilitation in palliative care, and it's becoming more common. I mean, allied health and rehabilitation in palliative care is well recognized, meeting the patient's physical, psychological, social, and spiritual needs. And is adapted, it tried to fit into the biosocial approach of the healthcare, which was suggested by the healthcare organization as well. I mean, in spite how we fit into this palliative care, into this huge field of palliative care or terminal care, in spite of the possible benefits, I mean, evidence do suggest as a deficiency of palliative care patients receiving or getting treatment. I mean, that sometimes can be challenging as well, and depending on the socioeconomic status and the cultural differences as well, which I'll try to explain as we go on to the presentation as well. And one of the basic things I realized when I started the job in 2008 is definitely changed quite a lot in the last decade. But when I started, initially there was a reluctance and unwillingness of referrals sending for a physio to a palliative care or end of life care as well. And sometimes that is probably not a good thing from a patient's perspective as well, because the patient was almost kind of denied of getting this fantastic service wherein he was treated, where the patient was treated in ensuring that they improve the quality of life. I mean, that has definitely changed in the past decade. I mean, in the patients with life-limiting illness as well, one of the things I struggle still is understanding about where do I fit in. I mean, that was a big challenge. I mean, you can imagine not knowing anything about hospice care or palliative care or end-of-life care, and a person who wants to become a sports physio and then end up being thrown into this huge ocean of patient care, where the expectation was I would say inadequate and sometimes or unclear. And that's where I found it extremely challenging in understanding the physio fitting in, because as we know, as a physio, we work on things that would help them to minimize the symptoms and optimizing of the function in the hope that they would get better and perform in a way that they want to do. That could be functional, that could be physical as well. But the huge component that comes into play in palliative care is a psychosocial component of it, which as a part of the training I received in Manipal was missing, I must say. I mean, the pure focus was for us to try and work with the patients to get them better, to get them walk, to get them run, to get them back to what they've been doing before they had the injury, before they have the illness as well. That's where I felt I learned so much in terms of adding that psychosocial, psychological dimension to the work we do. And that is the main difference where I see from my experience is the physical, other than the physical and the physiological dimension, the psychological dimension into the palliative care for a physio is extremely important as well. And which I'll try to see if I can kind of decimate that and see if I can split that to see if I can explain how that means, how we tackle that, and what are the resources that are on offer, and then how do we simplify that to ensure that being as a physio that we can work on the psychosocial side of things as well. And sometimes it's not purely done by reading it or by listening to it. It's done only by work experience as well. I mean, that's where if anybody's wanting to start an unclear, I would just say, just start working towards that, developing that dimension within yourself. And I'll talk through about what I've done to enhance or improve my psychological dimension as a physio to ensure that I perform the job that kept me in the job for the past decade, and then hoping that people are valuing that side of input as well, along with the physical dimension of what we do. When communication becomes a huge part within that, where if you can't communicate what you can do, what you can offer, it is impossible for you to convey what you want to do. I mean, that was my problem when I was as an undergraduate in Manipal in India, where I could not communicate well enough theoretically what is meant, what was expected of me from either could be an internal viva, or could be if any of the tutors or any of the teachers, any of the lecturers asked me what I want, what I know about specific things. I wasn't able to clearly communicate that towards that as well. Part of the problem was that I wasn't paying much attention to what was taught, and I wasn't trying hard enough to understand and then to explain what I want to say as well. And that reflected on my marks, to be honest, because during the viva as well, I wouldn't make it quite difficult for the examiner, even the internal examiner as well, where they tried to help me out to get the answers from me. Basically, I would say, I don't know the answer. And also sometimes, even though what I know, I struggle to put that point across in a way that would understand, that would get me the marks or the credentials that was required for me to clear that subject. And that still kind of surprises me, is even with that poor communication of my subject, or delivering that communication to whom I want to say, even with that, I still managed to escape through. But I wish if I had the same level of communication skills that I have right now, I wouldn't say I've mastered it, but at least I've acknowledged what my strengths are within those communication skills, so that I can put my point across so the person can understand. Sometimes that might not make any sense, but I'm able to put that point across in a much more effective way. And that has only improved by working in palliative care. And it is imperative, it is important, it's a core dimension for anybody wanting to perceive in any field. I would say communication is important. I mean, that could be verbal, that could be written. Some people are brilliant in writing and conveying what they want to convey. Some people would verbalize, some people would gesture, some people would act. So it's a way of finding what is your strength and what is that is important. I mean, sometimes it's hard for you to know what it is, but get the feedback from your supervisors or from your lecturers, from your professors, or even from your peers or from your friends. Talk it out to them, and then identify a medium of your way of communicating. Only by that way you can explore or you can explain what you want to say. And that is extremely important in order to master, in order to acknowledge your way of knowing more about the psychosocial model or the psychological component when mentioned earlier on as well. One of the key things in palliative care or in any patient care or any customer care is active listening. And then as healthcare professionals, I'm not speaking for everybody, but most of us, or I can speak to myself in many ways, where I used to listen to respond, because what the patients would come to you is they want you to respond to what they say. But in the process, what we tend to do is to struggle to understand what they're saying exactly, because we are so focused on responding to what the patient was saying as well. Sometimes it makes it harder for you to actually understand what they're saying. So what I've learned so far is by active listening, hear what people are really saying. And it's one of the important skills that you will have. And the success of active listening would have a huge impact on what you can deliver and how you deliver it. And then on that, I mean, it helps how your relationship with your friends, with your lecturers. I mean, sometimes that is harder. That is harder to master it, but it can only become easier if you practice more at it. I mean, how do you do active listening? And first and foremost important thing I wish I would have done this when I was an undergraduate, was to pay attention. I earlier on in my job in here, I used a Nintendo Wii as a game to enable them to have more fun in what they do. Another patient where I worked with him to take him to watch a football game. My aim was to get him to a football game, but he thought that he couldn't be able to do it because the way his mobility is, the way his pain levels are, and his confidence level, and his physical body image as well. So we managed to work with him in understanding that a physio can do the things that would enable him to improve his balance a little bit, enough for him to be sitting in a wheelchair from a bed, or we use an equipment called hoist, just lifting him up from the bed onto the chair. And we worked on his sitting balance just purely by giving him some upper limb exercises, long enough for him to sustain the football game, or work with him with his anxiety as well, his body image, and ensuring that he could get his football dress on, and working so that he's get a good presentation of himself. He's got a good football scarf as well, so that we worked on his balance, we worked on his sitting balance, his ability to transfer from bed to the chair, and we've done a trial run for taking him out in a wheelchair to a football game as well. So thereby the expectation was from him was nothing at the very beginning. He thought he's dying, he never would be able to go to a football game, and it's impossible, and that was causing him kind of quite worried in terms of, and then because he wants to see this game before he die, and that might be his last wish. But at no point he thought that was possible, that we could only do that with not only a physio but a multidisciplinary approach, where the medical staff was able to control his symptoms by providing him or prescribing him adequate pain relief that would keep his pain at bay. From an occupational therapist point of view, they've done enough adaptations in terms of his needs within the room. As a physio, I worked with him in enabling and maintain the range of motion, ensuring that there's no tightness or stiffness in his muscles and joints, and also worked on different positions that would not make him tired, that would enable him to withstand sitting him for the length of that time. A social worker came in and worked out with his family as well, controlling his emotions. and also the anxiety levels. Our fundraising team has managed to source football tickets for him to go and watch the game. So it took about 6 weeks of planning, but we know that at that time that this patient had that time to survive, to go to watch the football game. But sometimes that might not happen. You can make the best plans in the world, and palliative care, things change kind of quite suddenly as well. I mean, sometimes it changed so drastically where you could see somebody walking into the unit and then die the same day. I mean, I've seen, I mean, it doesn't happen often, but it does happen, is that you need to prepare yourself that you can make the best plans in the world, and you want to do these A, B, C things for the patients, but it might not happen at all. So that's where I felt quite guilty at the very beginning when I started working here, because I want to do so much for this patient. I would just push myself, and feel absolutely gutted of not able to deliver. And I thought it was part of my lack of experience and my lack of understanding about the condition that is causing that. But no, it's not your fault. And that's what I realized, and I'm still realizing. Sometimes you do feel guilty that I want to do this for the patients. Now what I'm trying to do is by actively listening, by practicing that listening, is understanding, no, it's not what I want for the patient, it's what patient wants from me. And what could I offer them? That is irrelevant sometimes. What is expected of the patient from me? And genuinely understanding that, and not dismissing the patient as well. Sometimes a request comes from him saying that you would see him lying in bed in agony, and then he wants to kind of walk. Or again, the football game as well, you could see them, he's dying, and then in a matter of days, and then he still wants to go out and watch this game. That is his need. So my job is to acknowledge that and find ways in working within the team in enabling that. How do I make this work? What are the things I need? That's where planning comes in play. But the planning should be as flexible as it can be, that it might not work at all. And don't feel guilty, don't feel disappointed that you can't make it happen. If you try to take it too personally as well, that would start affecting your way of thinking, that would compensate your skills in helping other patient as well. So that is where my biggest learning point is how do I do that? Because physically, as a physiotherapist, I want to get them better, I want to get them moving. But how do I understand them as a person? That wasn't taught in the undergraduate course at all. That can only happen with experience. That can only happen by changing your approach. That can only happen by working on your communication skills, and in a way of paying more attention what the person is saying. Thereby, you tailor those interventions that you learned in undergraduate. That could be providing passive exercises, but how do you adapt that? And practicing that with practicing the communication skills and the physical things that you learn in your undergraduate courses, coupling that would only way probably that would help you to implement or plan the interventions that you want to deliver to the patients as well. Sometimes, even though you see the person wanting to do certain things, but you know that's not going to happen, and you need to communicate that clearly and then be honest and be genuine with the person. He might hate you for saying those things wherein you say that he can't walk again, or they might be highly unlikely that he will walk again. He will hate you for it, and he doesn't want to speak to you, and he would just shut the doors on you as well. And then sometimes might be verbally a bit more, I wouldn't say abusive, but verbally a bit more stronger towards you, saying that, who are you to say that I can't walk again? I'll prove it to myself. Sometimes you need to acknowledge that. And even though in yourself and within your team that you know that this person can't walk again, and you communicate that to the person, but do not completely dismiss that, because it is only your expression, it is only your judgment, only your way of thinking that this person can't walk again, based on what you read in this case file, based on what the clinical presentation was. But sometimes the true grit of a person, you can't undermine that. You respect his wish, find a way for him to try, sometimes to fail. But it's okay, because he knows that he can't do it, but he wants to try to do it. And sometimes you know that you are doing it to kind of the outcome would be is that he might not walk again, but you need to get him to do it. But within the safety parameters as well, because you don't want to be doing things that would result in a fall, that could result in an injury. Because you have to make sure you set up those parameters, you do the risk assessment, and try the intervention in a way that he understands in himself that he can't do it as again. Sometimes he would come to you at that time, even that time as well, that might make his anxiety worse, that can make his pain worse as well. That's where the multidisciplinary comes in play, in keeping at bay some of the symptoms that would enable you to do it as well. In certain cases, you would clearly know, mainly for patients who's paralyzed, that he can't walk again. Do not try to move them, because obviously the patient presentation is such that you physically can't move him or get him on the feet as well. So future is vast. It can do so many things, and then there's no limitations. There's no set protocol for palliative care physio, but there are things that you can do wonders, kind of, in if you have the right mindset, if you have the right approach, and wanting to bear the burden of the emotional distress and the demand that puts upon you. For example, last week we're only 12-bed unit, but within that 12-bed unit, we lost 6 patients in 3 days. 6 patients died within a matter of 3 days. Where sometimes it creates a huge burden on you, and you want to help everybody that are there, but you can't. And it's important for you to acknowledge that, and always emotionally, if you are getting close to a person, knowing them for a period of time, find ways to unwind that emotion, find ways to dislodge that from your system, because we are human. There will be a breaking point for everybody. I mean, there are times where I cried, there are times where I laughed, there are times where I giggled, there are times where I've just jumped up in the air thinking that I've achieved something, because I've done that when I've taken this patient to a football game, because his consultant, his oncology consultant, has dismissed that idea that he could never sit up. And even coming here, looking at him as well, it was kind of near to impossible for the person to be sitting up as well. But we worked as a team in understanding the needs and acknowledge those needs, and even though somewhere down the line I thought that's not possible, but we kind of put our feet in his shoes and think that, okay, what if I want to do the same? And what if I haven't tried to doing it as well? Because up until that time, everybody said I couldn't do it. So we kind of managed to do that, and that's the happiest moment in some ways at that time. And other one as well, where I worked with a patient with MND, motor neuron disease, where I saw him as an outpatient, where he was coming to see me to improve his probably pain and range and posture as well. And I was with him almost to the point where he died. I was present in the room when he died. So I can kind of, the journey is an experience for me, probably that sums up my job as a palliative care physio, is working with somebody who first you saw him walking through the doors to see you, to the point where he's had his last breath. I mean, that is a beautiful experience for me as well. And knowing me as a person, knowing that I can't be judgmental, and I need to work on my listening skills. I need to listen to him, what his needs are. and understanding the basics of what goes on within that condition as well, because you need to know the trajectory of how that specific condition would affect that person as well. And knowing that in the background helps you to plan the interventions, but not necessarily that is the core thing. Put that aside on one plate and then listen to the person, because given one condition, two people react entirely differently. What I've learned from this person was, how do I work on my psychological skills? How do I work on my counseling skills in many ways, where there was a loss at each and every step of the way. I mean, from the first time I saw him walking into the building to the day he had his last breath was only a matter of 6 months. And even before, the day before he died, he called me to his room and he said the best thing that happened to him during this journey was to know me as a person. And kind of without any knowledge, I mean, without kind of what my tears in my eyes, and I start crying there. I don't know why, because nobody said that to me, where somebody's actually dying and then he could hardly speak up. But he told that to me because he wanted to acknowledge what I've done to him as a person, not as a physio. So sometimes it is challenging to be in that situation. It might not be for everybody who get emotionally kind of connected easily. That would start affecting their personal life. So I wouldn't recommend for this to anybody who would have any anxieties of doing it, but at least I would ask them to try. It doesn't matter which field of physiotherapy you are in. I would ask them to try for 6 months to 1 year, and not putting your skills to practice, but to learn about how to know a person. You might not know everything, but you might know by communicating with them or by practicing the active listening is what can I offer for this person, what the person wants from me. Sometimes that is important for us to know as a person, not as a professional as well, is understand what they're saying to us in order for you to respond in a better way possible. Practice, be open, be compassionate, be more self-aware of yourself. I mean, sometimes we are not blessed with, I mean, I'm not blessed with, as I said, fantastic academic skills. But what I try to practice is knowing the person who comes to me and finding ways. Could be something not in the books. To think out of books, kind of think about different ways, but make sure you set your parameters so that you're not hurting the person. So, and be confident. Practice in yourself, and be yourself. Sometimes it's hard. It's hard because you want to impersonate, or you want to get inspired, and you want to prove it to somebody that you can do these things. No, you don't have to prove it to anybody but to yourself, that whatever you're learning as an undergraduate there is sometimes you might not cover everything, but it might give you the confidence that you have the skills. But without you practicing that, you would find it really, really hard to go any further in whatever you're doing as well. So I think any questions that you may have, I hope I was able to kind of pass on or put my point across. I'm happy to take any questions or anybody, or first and foremost thing, has it made any sense? I hope it does. And has it helped you to understand more about palliative care? I'm not sure, because I haven't gone in depth of the integrities of what we do, but I try to share my experiences of what was challenging for me when I started the job, and then what stage I'm at now. I mean, I'm more self-aware of myself. I kind of try to work on my strengths, and I understand and acknowledge my weaknesses, and try to convert those weaknesses into my strengths. And within that, I'm more open. I'm honest to myself in the first place. I'm honest to the person who's coming to me. And if I don't know, I would still say I don't know. It's okay to say you don't know, and you don't have to pretend that you know. Sometimes being that genuineness and then being that honest helps you in a long way. I mean, sometimes don't say that when you're in an exam, when you're doing an exam in a Viva as well. I said I don't know. I mean, my lecturer at that time tried to pull me out, but if I don't know, I can't make up things, and the more I make up, I make blunders as well. So, yeah.
Yeah, thank you so much, Giridhar, for the wonderful session. So you have been prudent. You can disable your screen and you can
Okay,
show.
sir.
Yeah, so you have been prudent in telling, in admitting that despite having difficulties, right? So you have told that there are some limitations, right?
Yes.
But shared your knowledge about this palliative care as well as the skills what physiotherapist should have. So of course it's a very difficult topic because palliative care as such itself it requires a lot of compassion, empathy, lot of patience. So it is not possible. It is more like feeling rather than listening. So
Yes.
person has to feel themselves in that context to
Yeah.
know more about, to experience those feelings. So in that sense, you made your point, and we are very happy that you are able to articulate very well the basic skills required for a physiotherapist in palliative care or end of life care settings. So I request to the participants to please unmute yourself. You can ask questions to the resource faculty. If any questions are there, please feel free to answer your questions. Your questions will help us to understand whether you have whether you understood the concepts, right? So in case it can bring in more clarity to other listeners as well. So please, if anyone has got any questions, please feel free to put forward the questions to the resource faculty.
Yeah, I've just seen a question from Kalpana. Hello, sir. It was a wonderful session. Thank you. Is there a particular field of masters? There are, I mean, as a master's diploma in palliative care medicine, and I'm not sure, is there any specific for physios as such? I'm not aware of it, but I'm sure that I'm definitely aware that there's a diploma in palliative care medicine. I mean, the concept is that you try to help somebody to improve the quality of life. I mean, when I mentioned about the communication skills as well, it is pertinent or imperative that you need to have those communication skills and whatever chosen field of career you are in or whatever field you are in as well. If you can, that can only happen by practicing it. You're not born with it. I mean, only two things that you're born with are fear of falling and fear of loud noises, and everything is an acquired behavior. So that means you can learn it. You can learn to communicate. But how do you communicate? How do you learn it? Is by practicing it. Practicing with yourself in the mirror. Practice yourself to the person whom you want to say, or probably put a plaster in your mouth in terms of so that you don't speak up or you don't interrupt the person as well. And when you are listening as well, try to kind of minimize the distractions and try to see if you can focus by looking at the person. Sometimes it depends on how you see it as well. You might not pick up everything. You might not remind everything as well. I just briefly kind of mention about cone of experience by Dean Elgar, where he says we only remember about 10% of what we read, and we remember 20% of in a lecture what we hear. 30% will remember better, up to 30% by watching the pictures, still pictures. Kind of between 30 and 40, it goes when you saw a motion or a movie. Or 50% when you combine your vision and you're seeing what you're seeing and what you're hearing, and watching a demonstration like what you've done now, and 70% in participating hands-on workshop, and 90% is direct purposeful experience. So if you can see it as well, I mean, there's different layers of it as well. And I'm only trying to work on the 90%, trying to master the 90% where you work, you do it in order to know it as well. So going back to your question, Kalpana, is you can perceive a diploma in palliative care medicine that would help you to understand about what you can offer, and you can find an intervention or find yourself in there is how do you integrate yourself into that. A question from Ria, how do you deal with extreme feelings to get after you realize that the person you treated is no more? That's a good question, Ria. I mean, it's challenging. I would say it was never easy. I mean, you get immune to it, but you get to acknowledge that, and you need to acknowledge that. And then where we have a lot of staff debriefing as well, we do a lot of reflective practice. And my way of doing that is sometimes playing cricket. I mean, I go back to my cricket because that's my first life. And you need to find a ways of unwinding that and opening up yourself so that you do entirely different thing than what you've done, so that your emotions kind of, you translate that emotion to that activity and you bring that focus onto that activity. Speaking to the person that can listen to you, or I speak to my mother, my wife, or doing something with your children, I mean, or anybody, kids, because they come with their own agenda as well. Sometimes kind of, I wouldn't say distracting, but shifting your focus from that emotion to something entirely different, that sometimes helps me as well. Hope that's okay. But at every walk of life, you do take that emotional burden with you, but you need to find a medium of unlocking that. So, I mean,
Yes,
does it answer you, Ria? Is that helpful?
Yeah. Any participants? You can unmute yourself to ask questions. RPGs, anyone from physiotherapy and CHP? Do you have any questions?
Hello.
Yes.
Yeah,
Hello,
hi.
sir. So it was a great session, sir. So I wanted to ask how.
You can introduce yourself, please.
So I'm Nisha. I'm a geriatric PG from Physiotherapy Manipal.
Hi,
Sir,
Nisha.
I have a. Hello, sir. So I wanted to ask how palliative care is different from hospice care, sir.
Oh, that's a good question. Palliative care is about treating somebody who does not have any specific treatment intervention.
Okay.
So hospice care is I think the moment of hospice started probably about 35 years ago, where people are struggling to look after somebody who's dying with a lot many complex symptoms as well, like pain, could be breathlessness. It's about this organization was kind of founded or started to look after as possible. That could be pain medication, could be symptom control, that could be in helping them to move a little bit better from a physio point of view.
Okay. Thank you, sir.
Right.
Yes, participants, instead of typing, you can pose your questions directly.
Hello.
Hi.
Yeah, I'm Anisha. I'm doing my master's in cardiopulmonary physiotherapy.
Hi.
So could you please elaborate or like tell us a little bit more about your experience in cardiopulmonary side, respiratory?
Respiratory, in the past 2 years, thank you for the question. In the past 2 years, up until that time, my role in respiratory physio is predominantly for folks with extreme breathlessness. to the point where they can't even breathe. You can't even speak because of breathlessness, and also clearing of chest secretions as well. Where I try to use techniques, but sometimes don't have strong cough at all to clear those secretions. And there are a lot more folks that come to us in the terminal stages of COPD and pulmonary fibrosis, and we are lost. I mean, we are lost at that time where the patient came in and then he's not dying, and then that we were struggling because we are so good in here in looking after patients who are dying. Then oromorph in a way of nasal spray called fentanyl, which kind of a spray that acts within 5 minutes and stays in your system for an hour and does not have as severe side effects as the oromorph does. So we worked on that and got him to work on his breathing. I mean, as you know, probably breathing is an autonomous function. We are not aware of our breathing. We should not be aware of it for any length of time. But he was, every time he get breathless, he was trying to breathe in more. That means he was trying to engage his accessory muscles. And he was only kind of breathing into the anatomical dead space. And the air was not going into the lungs for it to be perfused so that he can get oxygen into his system. So we spoke to the consultant and then thought of what's the ways that we can try this. Is the best thing he suggested was when you get breathless, try to get them to breathe out more. Within the out breaths, he lose the focus of breathing in. That means he would physically and passively engage his accessory muscles to relax by breathing out. So by that way, his recovery time is better, and the air which was trapped in the anatomical dead space in here would kind of breathing dead space in there would go into the lungs as well, and thereby using the communication skills, as I mentioned earlier on, is what does the patient want to do? What is causing the breathlessness? Why? What was his thinking? And probably a cognitive behavioral therapy approach where asking him, what's stopping you doing these things is breathlessness. And then the next question we would ask him is, what can you do to make it better? I take medication. Does it get better? Yes. Does it help you to move or not much? Then the next question is, what's stopping you moving? So kind of in simplifying that and then breaking that down as well, and also his goal might be able to walk to the toilet, which is about 5 meters away. But our primary goal should be is how do you get them to understand his symptoms better by communicating him clearly that what he can do could be a small handheld fan. So and give him that resources in a platter to him and saying that when you get breathless, try these things, irrespective of the condition, what's causing the breathlessness. Because anxiety is a huge component, his underlying condition is a huge component as well. So I need to have an understanding of what is causing the breathlessness. I can only know that by discussing that with the multidisciplinary team, by the fellow physios already working with that patient, or to the concerned physician, to the concerned consultant, and being honest and asking him that I'm not sure about what's causing the breathlessness. Is there anything happening with the person's condition that's causing it? Once we know that there is a psychological component to that aspect of breathlessness, combined with its underlying condition, you try to not to separate it, but try to see if you can find a way that in explaining so that he can understand what you're trying to say, and listening to him what he's saying to us, and then finding a middle ground as well. So next time, probably when you see a breathlessness patient, is ask what does he do, and he might the first thing he want to do is going back onto the medication that he wants to do as well. But as a physio, we can do quite a lot for these patients. Could be simply getting them to adapt positions that minimize or help them recover from breathlessness, and how to kind of dysfunctional breathing, how to kind of make it to more an autonomous breathing, because most of the patients who are breathless want to breathe in more. Thereby you're disrupting your respiratory center. So you're trying to find him ways where all the techniques and the interventions that you do is to reset that so that it goes back to the automatic function or automatic function as well.
Yes, sir. Thank you, sir.
Right.
Any other questions?
There's one for Suchita Rao. Finally, a PG pursuing masters in geriatrics. My question is that what can our role prevent aspiration prevention patient undergoing palliative care? Aspiration in terms of, I mean, what we do is part of the bigger problem for us as well in here. I mean, what I do personally, we're working with our nursing staff and on the occupational therapist as well, and also probably referring them to the speech and language therapist as well, and understanding is what is causing the aspiration. I mean, what in terms of adapting what they eat as well. From my point of view, try to work on the positioning as well and ensuring that they're not aspirating easily, and then also sometimes which is harder to manage, mainly for patients who are with us. Sometimes the speech and language therapist might say he's nil by mouth, and some of the patients with motor neuron disease aspirate on their own secretions as a saliva. That's where the medical staff can prescribe them. I think it's Buscopan. I'm not sure. Sarah, who is a neurophysio, might be able to help me in here in kind of minimizing the saliva secretions as well, so that they don't aspirate on their own saliva as well. So from my point of view, purely focused on positioning, and with an input from a speech and language therapist and occupational therapist, and communicating that to the healthcare assistants who are helping the care of the person, and also the nursing staff who are delivering the care as well, and the medical staff. Is there any medication that would help them to kind of minimize if they are kind of aspirating on the saliva? Is that okay, Suchita? I mean, if I'm not able to answer any of your questions, I am happy to refer that with my physio colleagues or the medical staff in here, and then probably give them all, probably forward the right resources so that I can easily point out towards that as well. So my apologies if I'm not able to answer your question based on what you want to know. But please be honest with me, and then so that I know what I'm saying is making sense, pertinent to your question. If it's not clear, please do say that to me. I won't feel offended. I will try to reach to the right resource to get the right appropriate answer to that question.
I'm just seeing someone typing the question.
Yes, sir. Yeah.
Yeah, participant named Navneet Ravi.
Yes, sir.
Can you please pose your question? A participant named Navneet Ravi was typing something. Can you please pose the questions directly instead of typing?
Hello.
Hi.
Yes.
Yeah, I'm a UG from KMC Mangalore actually. Quite an informative session, sir. Maybe I missed the initial few minutes of the session, but can you just tell more about where exactly you pursued your master's from? Maybe I missed it. I don't know.
Yeah, I mean, as I previously mentioned, I wasn't a good student academically as well. So I've come to Edinburgh in Scotland to do master's.
Sorry for that. You need not repeat that again and again.
No.
Yeah.
So
No, what is you right now, that matters a lot.
no, but I need to know where it all started as well, sir. I thought probably, yeah, it's okay, yeah.
Yeah.
I've come to do my master's in Queen Margaret University in Edinburgh in Scotland, where I could not clear my dissertation at that time, and then I came out with postgrad diploma to change my work visa, student visa to work visa. When I started working here in the hospice supported me. My line manager at that time knew that probably I would want to know a little bit more. I need to know a little bit more what I need to do in terms of my role. And she's encouraged me to approach a different university, transferring my credits. I mean, you get certain credits after doing a postgrad diploma. And then I've transferred those credits to Sheffield Hallam University in Sheffield, where I've enrolled as a part-time master degree to do my dissertation on effectiveness of aerobic exercise in patients with undergone chemotherapy, because that was relevant to what I do at that time. And then my organization has supported for me to finish my master's at that time. So I've got my master degree from Sheffield Hallam University in Sheffield.
Okay, thank you, sir.
Yeah. Hello. Before this, can you introduce yourself? A participant, one who has asked question right now.
Yeah, I said, sir. I'm Navneet from. I'm an
Okay,
undergrad student at KMC Mangalore.
Okay. Okay. Thank you. Thank you so much for joining us.
Okay.
Yeah. Any other question? Thank you so much, each one of you, for participating in this first session of our Physiotherapy MCHP Global Alumni Webinar Series. And in fact, we are very much thankful to Mr. Giridhar Ravi, our esteemed alumnus of BPT 2000 batch, who has accepted our request, and he has responded positively in sharing his knowledge and expertise in the field of palliative and end-of-life care. So thank you so much, Giridhar, for joining us and sharing your experiences with not only with our students but also global alumni. I see others have also joined this session. So being the first session, so we have seen close to 40 numbers participants who have registered for this session. So it is to start with, it is a good response. So your thoughts, Ravi?
I mean, first of all, thank you so much for listening. I mean, I talked about so much about listening skills. I hope you had a chance to practice those listening skills. And secondly, I'm happy to help anybody whom you think probably I might be able to help at all in anything that you think. If you don't ask, nobody would know what you want to know. So please don't be hesitant in asking. And then I mean, you can contact me via any social media platforms that you can connect to me, or you can have my email address or anything at all. If anything that you would want to ask one-to-one, or I'm happy to speak at any length, and as long as you understand what I want to say to you, and I'm happy to help in any ways possible to help you to go on to the next step.
Yeah, the very purpose of having such webinar series, beyond the academic enrichment, we wanted to connect alumnus. So we wanted each one to get connected with each other so that they find the right people, right resource for their interest areas. And we have Giridhar from Scotland in the field of palliative and end-of-life care. So thank you so much, Giridhar. So on behalf of Physiotherapy, MCHP, and the entire team of faculty members, HOD, I sincerely appreciate your support for this webinar and sharing your knowledge and expertise. Thank you so much for joining.
No problem, sir. Everybody stay safe and take care.
Thank you so much. Thank you.
Bye.
Bye. Bye. Bye.